Hello and welcome to ETHealthWorld. Now, as we know, epilepsy affects nearly 10 million of people in India, yet 1 out of every 3 patients doesn't respond to medication. And that's what we call drug-resistant epilepsy or DRE. Now, for these patients, surgery can be life-changing, but awareness about it is still surprisingly low. Now, today we are joined in by two of India's foremost experts from AIIMS New Delhi. Please join me in welcoming Professor Dr. P. Sarat Chandra and Professor Dr. Manjari Tripathi to talk about what's new in epilepsy care, how solutions are evolving, and of course, how technologies from partners like Brainlab are helping make treatment more precise and accessible. Well, thank you so much for joining us for this conversation. And let me start with you, Dr. Chandra. Let's start with the big picture. When we talk about epilepsy, it affects millions of people. Yet, when we talk about the challenges, they go beyond seizures themselves. So, from your experience, what does the real burden of epilepsy look like on patients, on parents, on workplaces?
So, what we have, first of all, is the actual burden, which is not trivial. There are about 50 million people who suffer from epilepsy worldwide.
Yeah.
And over 10 to 12 million in India as per the extrapolated statistics. We don't have the actual statistics, but as per whatever epidemiological studies we have done, that is the amount of figure which comes out. And this is one challenge. The other challenge is the immense treatment gap which is faced with epilepsy, because this disease is a very peculiar disease in the sense that not only there is a definite issues regarding the treatment and its prevalence and incidence, but also the created prevalence and incidence which happens because of various other factors like stigma, superstitions, lack of availability of treatment in most of the tier 3 or even to the rural areas. And the other factor being that most of the doctors or physicians themselves do not have adequate knowledge on how to treat epilepsy. Because as of today, we have almost 24 drugs available in the market. But the way you have to provide either monotherapy or polytherapy to any patient will highly depend upon what is the type of epilepsy, what is the semiology of epilepsy, what is the diagnosis of epilepsy, and then the adequate medicine to be given and how it is to be adequately combined with other medicine. So there are bottlenecks at every stage. First is you have the incidence, then you have the bottleneck because of the treatment gap, which is because of the superstitions or because of the stigma associated with it. And then you have bottlenecks about the physician, lack of efficacy of the physician to be able to deliver effective treatment to the patient and patients.
Yeah, thank you for setting the context for us. Now taking the point across to you, ma'am, as well. When it comes to the options, despite decades of progress, as he was also talking about, there is a lack of awareness, right? Many people don't know about the surgery options as well. So where do you find that gap? Where do you see that gap? Is it because the lack of knowledge? Is it because of the fear? Is it because of the stigma that he was talking about? What it is actually?
So actually the first step is, giving the patient one single medication. And if they fail that one single anti-seizure medication, adding on a second. And if they fail two, either in combination or in succession, then obviously the patient moves on to the category of drug-resistant epilepsy. Now, unfortunately, the first level of failure is the fact that not adequate doses of these medicines are given and not the appropriately chosen medicines are given. And because there are so many medications, the physicians try to keep adding one after the other. So there are several patients who are on 4 drugs, 5 drugs, some of them in suboptimal doses. And this addition, every time a patient goes with a recurrence, there's another addition. This delays their recognition as being drug resistant. So the first step is failure to identify drug resistance at the basic primary physician level or even a neurologist level. Many neurologists may not want to give away the patient, particularly if they are in practice. They may want to retain the patient and keep giving one medication after the other, one medication after the other. Then the second is, of course, the fact that these patients may be just too scared of the word surgery. which actually is not true, because there are so many safer methods of surgery now, and it's no more something which is to be feared of. The third is, of course, that there would be a limitation of resources or the hospitals with those resources. So for evaluation of drug resistance, you require very specific technologies. And these specific technologies are available in some national institutes and some private institutes. So basically, they are the hubs for the management and evaluation of these patients. Now, a referral pathway right from the rural area to the district hospital, to the state level medical college, to or a private center in the state, followed by to these hubs. So it's like a hub and spoke model. That hub and spoke model is not very, very streamlined. The reason being that many of the doctors themselves may not be aware that this could be a candidate who will benefit from further evaluation, especially if they're not responding.
Thank you for sharing that point and taking that point on the drug resistance across to you as well, sir. When we talk about the drug-resistant epilepsy, first of all, start by explaining what it is actually. How do we define that? And also, when should patients or families know, that now this is the time that medications are not working?
That's a very good and relevant question you asked. I'm happy about it. So like Dr. Manjari was saying, drug resistance by the International League is defined as failure of two optimally combined medications in their optimal dosage. And there is no time period for the failure, even though generally we consider about 1 year. But in some categories of patients, for instance, pediatric patients, they could be having number of seizures. So waiting for 1 year may not, be logical. Similarly, some patients may have a very well-defined substrate on MRI. So you can see some kind of thing on the MRI on which you can operate or you can cure the patient. So again, we're waiting for a long time doesn't make any sense. But what is more important from an ordinary person's perspective is that if the first drug, if given properly in the proper dose and is the correct medicine for that type of seizure, if the patient fails the first medication, the chance of that patient having drug resistance is close to 50%. So that is the first red flag. So when the first correct medication in its correct dosage has failed, that could be a red flag for the physician that perhaps this patient could be having a drug-resistant epilepsy. And one has to understand that drug-resistant epilepsy is not same as antibiotic resistance. It's totally different. By antibiotic resistance, we mean that we keep on giving a lot of antibiotics and over a period of time, the microbiomes have developed resistance against the antibiotics. In drug-resistant epilepsy, we mean that this person has a neurobiological constitution right from beginning itself, that this person is drug resistant, is not going to respond to drugs. So it's possible that we could identify drug resistant epilepsy very early in the course of disease. But unfortunately, that doesn't happen. Even in developed countries like US, there is a significant gap. In India, we did a preliminary study at the All India Institute and we found that the average gap of referral for a patient before he or she is diagnosed as drug resistance is around 15 years. So they undergo 15 years of continuous therapy with 3 drugs, 4 drugs, 5 drugs. And one has to understand that whenever you start a new medication, there is always this honeymoon period for 6 months where there is some degree of response, which again brings a hope to the patients and their caregivers. But again, there is a breakthrough seizures after 6 months, 7 months and 8 months. And understanding the fact that we have over 2 dozen medications, a physician can go on doing all permutations and combination for several years before they finally decide that this patient is drug resistant. So most of the physicians think that surgery is the last resort when no medicine is working, whereas the scientific evidence is contrary. It says right from beginning you can define who is the patient who could be drug resistant, and that patient at that stage itself should be referred to a tertiary institute or to a bigger institute where they are doing workup for drug-resistant epilepsies and its surgical management.
All right, thank you for sharing that. But Dr. Manjari, like he said that right from stage 1, perhaps we can look at the surgery options as well. So how do you sort of evaluate who is the right candidate for surgery, and then what happens next? I mean, tests, mapping, scans, what's the entire process?
Yes, so as soon as a person comes to us who's not responding to 2 or more medicines, we first try to establish whether it is a true resistance or a pseudo resistance.
Okay.
A pseudo resistance means we take 2 steps backward and we question the diagnosis, because there are many things which look like seizures and may not be seizures.
Yeah.
So, for example, functional dissociative seizures could be wrongly diagnosed as epilepsy. So we have to check the diagnosis first. The second is we check the drugs and check the doses. And we check the compliance to the medication. Once all this is in place and we have ruled out a pseudo resistance, then we know that we are dealing with a true resistance, in a person.
Okay.
In which case, the first step is to develop a clinical hypothesis as to where the seizure is coming from. Is it a focus, or is it a more regional area of the brain, or one hemisphere of the brain, or is it the whole brain? So this we can get from the history. And nowadays we ask them to bring the seizures on the home, videos on the mobiles. So we also have the history, which is telling us, the patient's caregiver will tell us whether the head is turning to the right or the eyes are going to the right, whether the patient is twisted on the right. And we corroborate that with the mobile phones videos. So now we know that the patient has seizures which are right focal and presumably coming from the left side of the brain.
Yeah.
And they are resistant. So we know that this patient is a patient we have to fast track for investigations. Now there are special investigations beyond this history taking and home video. The first is to find out which is the irritative zone, where the brain is, there are areas of the brain which are like spots of burning coal.
Okay.
So when you burn coal, either it catches fire or it slowly, shows its flame in different spots.
Yeah.
So those simmering spots are the irritative zone. Now that is picked up on the interictal EEG, which we do on outpatient basis, which usually is about 40 minutes, both awake and sleep.
Okay.
But the ictal onset zone, which is from where, that point from where the seizure is coming, we have to do another test in which the patient is admitted and we reduce the medicines to bring on the seizures. So this is known as the video EEG. So it's the video synchronized with the EEG. We try to capture 3 or more events. And after that, we do a very specific MRI, which is known as the epilepsy protocol MRI, in which very thin slices of the brain are taken. And this kind of MRI consumes about 45 minutes. Now, many centers which are, centers which are private centers, like you have in Delhi standalone MRI imaging centers, they will not do a brain MRI for more than 15 minutes. So it's a suboptimal MRI. An optimal epilepsy protocol MRI, which is known as the harness protocol, takes roughly about 45 to 50 minutes. Then, if we find that the video EEG, the MRI, the history, all are pointing to one area, we don't have to do any more tests. But very often we find that the video EEG showing finding from here, the MRI is showing a lesion here or at the back. And so then we proceed to further tests, which is known as the ictal SPECT, where we have to give a radionuclide substance into the intravenous system, and that tags on to the firing neurons to produce a hot spot. So we do an ictal SPECT, we do an interictal SPECT, and suppose the brain MRI is normal, then we even do a PET.
Okay.
Then there are further investigations where we have, in the video EEG, we just have, a 30 channel or a 20 channel EEG. But there is a further advanced investigation, which is available in India, which is known as magnetoencephalography. And this has 306 channels, which are inside a supercooled helium, chain. And the pickup of the magnetoencephalography is very precise. So we do MEG for 3 hours and we fuse it with the MRI. And so we have the imaging and we have the MEG signal, and we know furthermore precisely where the seizure is coming from. So these are all the preoperative investigations. Apart from this, we do a neuropsychological evaluation also. Because if the patient has a defect in the right temporal lobe with a shrinkage of the hippocampus, we have to make sure that the left temporal lobe is normal. Okay, psychologically, neuropsychologically, in terms of memory function. Because if we're going to remove this area, then the other area has to be able to balance out the area which we have removed. So these are basically all the tests which are done. So we have various snapshots in these various tests. Now we have to marry these snapshots together. So we have to fuse the MRI, the MEG, the PET, the SPECT, and the video EEG together, which is where precision-based platforms become very, very important, particularly for the surgeon. So there are platforms now which allow us to marry these different snapshots into one snapshot and be more precise to the exact anatomical area from where the seizure is coming.
No, definitely. And thank you for sharing that. We'll come back to the platforms and the technologies that you're talking about very soon, perhaps in the later half of this conversation, because that's important as well. But before that, as a neurologist, you're also a bridge between diagnosis and surgery, right? So how do you prepare your patients or families for that shift, both emotionally and also medically?
So the first step is they are already scared of surgery, and when they come to the outpatients, we tell them that, see, listen, all patients don't end up in surgery. We have other options, like we have specialized medicated diets, ketogenic diet, modified Atkins diet, low glycemic index diet. We do have specialized medications like cannabidiol, and we also have protocols in yoga for drug-resistant epilepsy, which if you are not a candidate for surgery, you will go through that pathway. So the reason we want to do these tests is to make sure that you are a candidate or not a candidate for surgery. So the quicker we do it, the better it is for the patient, because they have already lost out on their years. If it happens in childhood, they lose out on schooling. If it happens on a desk job, they lose out their job. If it happens to a housewife, she loses out on marriage. So they've already lost out on many of the aspirations they have. So this is the easiest way to explain to them. And then we also explain to them that with every seizure, there is more and more neurons which are dying out. And ultimately, if the seizures go on like that, the lifespan may not be as expected for a normal person. There could be a premature incident, which we know as SUDEP, which is otherwise known as sudden unexpected death in epilepsy, or they could burn themselves or injure themselves. So drug-resistant epilepsy is not benign, and that is why they need to come to a center where the evaluation can be done in a more comprehensive way to gain closure to the management options. If it's not a surgical case, if there are other options to be tried like diet, that's the pathway, or surgery is the pathway. They may choose it, they may not choose it. Very often, if they're hesitant about surgery, we ask them to speak to patients who have undergone surgery. Because for a doctor to explain is okay, but when they talk to patients who've already undergone a surgery, then they gain more confidence of the process. So that is how we discuss it.
All right, thank you for sharing that, Dr. Chandra. If you can come into the conversation. As she rightly said, when we talk about brain surgery, it's really daunting for a lot of people at the end of the day. So if you can demystify what actually happens in an epilepsy surgery and how technology perhaps has changed the entire scenario when it comes to what happens inside the OT.
So Dr. Manjari was saying that in epilepsy surgery, we are looking for a particular region where the seizures might be arising from. So earlier we would use the nomenclature of focus. So that shifted from region.
Okay.
And now we don't say that it's a region, we say it's a group of abnormal networks. Because epilepsy, it's a network disease.
Yeah.
So if you go to the YouTube and you can press on flight paths across the globe, you will see that it shows a video which runs just for 60 seconds, which shows all the flight paths going across the globe.
Yeah.
And you look at it, you find that, let us say, if somebody has to go from Bhatinda to, let us say, to Buffalo in US. So obviously there is no direct flight. You
Yeah.
would once first come to Delhi, and from Delhi you would go to New York, and from New York another flight to Bathinda. So this large airports which are connected with large international flights are called as nodes. So in brain also we have a reasons to believe, if the brain were to be connected randomly, it would use up 50% of body's metabolism, which it doesn't. So we believe that the pathways in the brain are very intelligently connected. So when we are looking at networks, we are looking at these nodes or abnormal areas from where you have, where these epileptic networks or abnormal networks, they arise or located in this area. Now, like Dr. Manjari was explaining, when we look at epilepsy, we are looking at an evolving and a dynamic event. So let us say brain tumor, it's a static event. You take one photograph, you know everything about it. Like there is a mountain, you take a photograph, that's it, it's a mountain. It's not going to change. If it's a tumor, you take one MRI, you know where the tumor is. But in epilepsy, you are looking at an evolving and dynamic event which changes over a period of time. So where it arises from, where it spreads, where it goes. So that is the reason we need to do multiple investigations. Because each of these investigations have a different time and a space stamp. For instance, MRI. MRI is very good in a space stamp, but it's very poor in a time stamp because it doesn't show how it is evolving over a period of time. Whereas other investigations like MEG, they are more like a dynamic event imaging. So they will show where it is arising from, where it is spreading to. And I have this joke, with my fellows and residents when I try to explain them how we plan epilepsy surgery. It's like trying to understand a Hindu wedding which is happening over 4 days. A simple snapshot is not going to do you justice. You need to have at least 50, 60, 70 photos to see how the whole thing, you have this pre-wedding ceremony, then you have post-wedding, then you have this. So in order to understand the whole event, you need multiple snapshots. So same thing in epilepsy, you need multiple investigations in order for you to understand where the abnormal networks are located. And the way to move forward is multimodal imaging. So about 15 years ago, when I was in UCLA, that's where we started doing multimodal imaging. So we combined PET with MRI. And we published it, and it has a citation of more than 600 right now, close to 1000 citations, which showed for the first time in tuberous sclerosis that when you combine a PET with an MRI, the tumor which is associated with the largest area of abnormality is likely to be the epileptogenic tumor. So in tuberous sclerosis, you have a child with multiple seizures and you have multiple abnormalities. So doing an MRI, it's not possible for you to say which tumor is actually firing and causing epilepsy. But if you combine a PET with an MRI, the tumor which has the highest degree of abnormality can be seen, and you say this is what is the abnormal area. More recently, we have advanced technology where you can combine all the imaging and put it in one frame of picture, which could be a 3D. So you could rotate this brain in all the directions and then say that this is the area which is MRI abnormal, this is the area which is PET abnormal, this is the area which is common to both, this is the SPECT, this is the MEG, and based on this, we plan surgery. So coming back to your question, when you say, how do I demystify surgery? So surgical approach is fundamentally very, very simple. So we are looking only at 3 processes. A, resective surgery, where we identify the abnormal networks and we remove it. So we are resecting it. So like a tumor, we are removing it. So that's called as resective surgery. The other surgery is called as a disconnective surgery. So what we are doing is, rather than removing a large chunk, we are just disconnecting its connections to the surrounding areas of the brain. And the third is neuromodulation, where we put some kind of a device which produces electrical activity and zaps those neurons so that these abnormal networks are no more active. You're kind of producing a lot of electricity so that these neurons are stunned. So they're no more active and no more producing. So in terms of surgical approaches, these are the 3 approaches, but you have different types of surgeries for each one of them. So that is why it's not a simple issue like any other surgery. For instance, DBS, you have only one target for doing DBS, but in epilepsy surgery, it's not the same. That's the reason you need a multi-team approach where you sit with the entire team and you discuss out that this is the kind of surgery which should be customized and tailored for this type of patient.
All right, thank you for sharing that, and perhaps we'll come back to on how technology is helping you to sort of integrate the systems like imaging you were talking about, or navigation or surgical planning effectively, and how there are other technological or advanced technologies that sort of assist you, especially during procedures like stereo EED electrode placement. And that's perhaps an important one. But before that, I'll come back to you, ma'am, on, we know that technology now plays a huge role in how epilepsy is diagnosed and managed, as you both were talking about as well. So from your experience, from your perspective, how these new tools, especially imaging and data integration, sort of improved your ability to sort of pinpoint the seizure focus areas?
So, as discussed, that we have these various snapshots which are available to us. And based on these snapshots, we develop a hypothesis that this is probably the onset area, and this is the propagation area or the spread area,
Okay.
and this is the area which is involved in the whole seizure at the end of the seizure.
Mhm.
Now, we really need to be able to localize the two-dimensional EEG. So when we do EEG, it is not on a 3-dimension. It is
Okay.
only on a screen.
Mhm.
So we have to convert that two-dimensional EEG
Mhm.
into a 3-dimensional space, because surgery is
Yeah.
on a 3-dimensional structure of the brain.
Hmm.
So to do that, we need specialized softwares, specialized platforms which are there, which will help convert this ictal onset, which we are seeing on the EEG, into a 3-dimensional space, which is by MRI. And MRI again is not totally 3-dimensional when you look at it in terms of looking at it on the screen, because you're just seeing a particular section. You're seeing the eggshell section, or you're seeing the coronal sections, which is like this, and the eggshell is like this. But when you have to see the whole brain in the 3-dimensional, you will need specialized platforms which will help you visualize that area in all 3 dimensions. Now, why is this important? Because we know that the brain has certain very eloquent areas, the areas which are expressive and which are needed for day-to-day function. So suppose you have a lesion, like just yesterday we did a surgery where the lesion was just in front of the hand and the leg area. Now, obviously, if you are not precise in that area and you are just going to do some kind of chopping off of whatever region you're seeing on the MRI, which is 2-dimensional, you may give the patient a weakness of the hand and the leg. But if you have a 3-dimensional orientation to that area in terms of the EEG onset, so you're seeing the brain and you're seeing that this is the hand and the leg area, okay, which is behind the ring of my finger, and the lesion is here. So you will know where the ictal onset is based on EEG, where it is based on SPECT, and where is it based on function, by doing a functional MRI. And you can fuse this in this platform and see the exact location and how much of it overlaps with this eloquent area of hand and leg area.
Okay.
Suppose there is no overlap, while doing the pre-surgical counseling, we can tell the relatives that there is a lesser chance of developing a weakness. If there is an overlap with the functional area of the brain based on fusion on this platform, then we have to counsel them beforehand. Look here, we are going to be very careful. The surgeon will have this available 3-dimensional picture in the operation theatre. We will also be doing intraoperative mapping of the motor cortex in the operation theatre. But since there is an overlap of the functional area with the pathological network, there could be a chance of a deficit. So that counseling and that preparedness has to be given to the family. Because if there is going to be a deficit, they need to be knowing about it, they need to be prepared about it, and they should also be prepared for post-surgical physiotherapy and rehabilitation. So that's very important that we are able to fuse all these snapshots on a 3-dimensional model to be exactly precise, because every millimeter of the cortex counts when it is close to these functional areas in the brain.
All right. Dr. Chandra, if you can also share on how these advanced technologies like Brainlab's technology, sort of for software and robotic systems, especially assist you during procedures like she was also talking about.
So continuing on the same theme what I've spoken earlier on how multimodal imaging fusion is important for epilepsy, because we are not looking at one static event, we are looking at an evolving and a dynamic event. So we need to know where it is arising and where it is spreading to. In addition, there are situations where you need to electrically map the brain. So what all things we have spoken about are all functional mapping. The only electrical mapping we have is the video EEG, which Dr. Manjari has spoken about. But over here, you're placing the electrodes on the surface of the head, which is outside the bone, and you may not get very accurate signals from it. So in some group of patients, we do not, even after all these investigations, we do not know what is the localization of the abnormal networks. And these are the group of patients where we need to do a procedure called as stereoelectroencephalography. Or it is pronounced as SEEG. And by this, what we do is using a robotic device, this is done under general anesthesia. We drill very thin, small holes which are about 2.1 millimeters, and we pass an electrode which is 0.8 millimeters thick into the brain. So these are long electrodes. And before we pass this electrode, we sit and plan out exactly where we are going to place these electrodes. So the placement of these electrodes are dictated by the multimodal imaging which is generated earlier, along with the hypothesis which is generated by the neurologist and our team that this is where the epilepsy is likely to arise, and that is where we put these electrodes so that we can further decode and find out where exactly the seizures are arising from. Now, once we put in these electrodes, we try to establish the hypothesis by three things. First is we record and look for spontaneous seizures where they are arising from. Second is we then stimulate these electrodes so that we can produce the habitual seizures. So the kind of seizures, let us say we are finding that there is a lot of an electrical activity from the right temporal lobe. Now we believe that right temporal lobe is abnormal. So in the second step, we stimulate these electrodes so that we are able to reproduce the seizure on the bed. And we even call the relatives and ask them, is this the same kind of seizure that your patient is having? And then they say yes. And the third step is what we do is we connect these electrodes to a generator and we burn these electrodes so that the area from where the seizures are arising from, that can be burned using the electrodes. Now we have found in our series, we have placed more than 600 electrodes and we have published it recently. We have found that approximately 40% of the patients have good outcomes just by burning these electrodes. So you don't have to subject these patients to a bigger surgery later on. But what is important is, about 60 or 70% of the patients, what happens is they are seizure free for some time. And then they start having seizures again. But now we know where the seizures are arising from because we have created an excellent hypothesis. And that is when we go ahead and do an open surgery and take it out. So using this technology, we are now able to tackle patients who have absolutely normal MRIs. So these are the patients who have undergone so many MRIs before they have actually come to our institute. And even here also, when we do surgeries, we do MRIs, we find that all the MRIs are absolutely same. Even more so, there's a paper which has come out recently. They say that even histopathologically, when you do surgery, the histopathology is normal. Which means we are now dealing with pathologies which are only electrically dysfunctional, but completely normal in terms of histopathology. And that is the area where we are advancing. So we are advancing very fast to very, very sophisticated areas where we find that imaging as per MRI is absolutely normal. But using the functional as well as electrical imaging and electrical source imaging, we are able to find which is the area where the networks are abnormal, where it produces seizures. And for us to be capable of this kind of technology, of this kind of procedures or this kind of surgical capabilities, we also need advanced technology, particularly where we can fuse all the imaging on one 3D model and we can even show where the electrodes are placed. Because once we place electrodes, we need to decide which are the electrodes we need to burn or which is the area which is coming which is abnormal, from where abnormal networks are being generated. And now we have technology where the whole thing can be imprinted on a 3D brain model, and we are able to turn this 3D brain model in all directions to see where exactly is the hypothesis where the seizures are arising from.
Yeah.
So this technology is called as post-processing imaging.
Okay.
So you are processing the imaging once the imaging has been done, so that you can have a bird's eye view to know holistically where are the location of abnormal networks.
All right, thank you for sharing that. I mean, with the help of technology, the advanced technologies that we are talking about, we can actually visualize or plan before even touching the patient. Right now, moving on to the collaboration part. You know, when we talk about epilepsy, Dr. Chandra, epilepsy care, it sits right at the intersection of neurology and neurosurgery, right? So how does that collaboration happen, especially in the complex DRE cases?
So see, one thing is very clear, epilepsy is very much a medical disease. 70% of epilepsies are treated with drugs. So it is very much within the spectrum of a neurologist. They have to decide what medicine is to be given, how much dosage is to be given, how it is to be combined with another drug, 2 drugs or 3 drugs. And then finally they have to take a decision that is it a drug resistant epilepsy or not. So once it's a drug resistant epilepsy, even they have to work up the patient, because they have immense knowledge about electrical, where the activities are, where the imaging is, how the EEG arises and all that. And that is done as a multi-team approach. And once it's done, that is when they tell us that, look here, this is where we think that the seizures abnormal networks are likely to be located. So how would you like to do the surgery? Would you like to remove it? Would you like to disconnect it? And then we have to, we have to convince them that this is the surgery which is best suited for them. And we often have fights. They say, no, why don't you do this surgery? Then we say, I think this surgery is enough. I think this surgery should be better. So that is why a team approach is very important. If you don't have a team approach, any epilepsy program is going to collapse. And that's one of the reasons in many of the centers, they've not been able to start a successful epilepsy surgery program. Because they have not been able to establish a collaborative team approach.
Yeah, and that exactly is my next question. Dr. Tripathi, if you can come to this conversation, the advances that we are talking about, the access to such comprehensive epilepsy care that we just spoke about is limited to very few major places, few major institutions only. Why it is that? Where are the barriers? Is it infrastructure? Is it the team thing that sir was talking about? Where do you see those barriers?
So really, you can do this when you come out of your comfort zone. And for a typical neurologist, the comfort zone would be sitting in the outpatient, seeing the patient, taking the history, writing the medicine and sending the patient off. You have to come out of that comfort zone and realize that there are these complex patients in whom medicines are not working, and they're coming again and again to you, and you have to find the solution. For that, you have to build up a team, and the initiative has to be the neurologist. They have to find neurosurgeon who's interested in devoting time to this precision-based therapy. You have to find a neuroimaging specialist who's willing to do a 45-minute MRI, because that's the time the patient will be in the MRI. Maybe 3 more patients will be, not be getting the MRI in these 45 minutes. So if it's a highly business-driven model where the center has to do 100 MRIs a day just because they have to make that much amount of capital gain, the team is not going to be working out. So you have to have the radiologist giving 45 minutes of the MRI to that patient. Then you have to have nuclear medicine specialists. So nuclear medicine specialist who's going to help you with the SPECT, the PET, the SysCom, the PASCOM. Then, of course, you have to have a magnetoencephalography unit. And fortunately, we were the first to have the unit in India. So you have to have that unit with highly trained technologists who are doing their source analysis. Source analysis means magnetoencephalography is the most accurate in terms of temporal and spatial, the time stamp and the space stamp. So we're getting that information from that investigation. Then you have to have the psychologist on board who's going to evaluate the patient's psychological capacity, intellectual capacity, behavior issues. Then you also have to have a dietitian on board. And then you have to have a specialist nurse on board who is able to explain to a certain extent the basic procedures. So this requires a lot of time and trying to get out of your comfort zone. Each of these specialists has to be out of their armchair mode of therapy. They have to be ready to dedicate 2 hours in a week for discussion of each case. So we do have our combined meetings, which all these specialists sit together on every Monday, 2:30 onwards till 4:30. So we just are sitting discussing case after case together. So the neurologist will present. Then the neuroradiologist will see where the imaging is. Then the nuclear medicine specialist will say, this is the area. Then the neurosurgeon will say, okay, now things are overlapping and so maybe we can remove this area. So it requires all of these people to be able to be sitting together across board, face to face, looking at the patient. I think it's very, very good because if you can do this in every hospital in this country where these facilities are available, particularly video EEG and MRI, then the burden of refractory epilepsy will come down. And why is that important? Because you are having a procedure in this group of patients which has the lowest number needed to treat for any intervention in medicine is for epilepsy surgery. You need to treat only 1.5 persons to make one person seizure free. Even aspirin doesn't have that number needed to treat to prevent stroke. So epilepsy surgery is a surgery which has the highest rewards in terms of outcomes for patients. It can transform the life of a patient from being homebound to being work-bound to being education-bound. So it is that transformative with that kind of number needed to treat. And hence, this motivation to form this team has to be built in and a nurturing has to be done for these teams at all hospitals. If you don't nurture the team, if the hospital administration doesn't nurture the team, then obviously things will fall apart. So teams are difficult to build, difficult to maintain, because every person has his own attitude, his own way to look forward. When many of these people come together with a common goal, focusing on this person with drug-resistant epilepsy, that's where things start.
That's a very pertinent point. And Dr. Chandra, if you can talk about this more in the sense that if you want to scale this up in a short-term perspective, then do you think that technology-driven collaboration models can be the potential, or do they have potential where, hospitals across India can sort of virtually connect with centers like AIIMS and sort of discuss around navigation or surgical planning or stuff?
So that's a very nice and a relevant question, but I'm just going to upscale on what Dr. Manjari has said into a more philosophical perspective. So if you have read the book called Blue Ocean Strategy, it's a book about showing how you can go into new areas which other people are not going. So metaphorically, they are divided into a red ocean and a blue ocean. The red ocean is red because there are too many sharks there that are eating each other. Its blood is getting spilled and that's why it's red. But paradoxically, most of the people would like to stay in red ocean because they think that is the comfort area. So for neurosurgeons, what are the comfort areas? It's tumors, it's spine surgery, it is endoscopic surgery, because they don't have to depend more on teams. They can do it individually. There's a lot of competition. You cannot contribute much, but then you say, okay, I'm okay because others are doing it. Whereas blue ocean is something where you like to start off something new, but you have an advantage that you are the only sailor in the blue ocean. There are no sharks there. Now, epilepsy surgery is a blue ocean. It's got enormous potential. But this is something people have to realize before we start connecting them technologically. They have to start realizing that epilepsy surgery has got the lowest number to treat. It is most rewarding. Hospital administrators have to understand that beyond their usual neurosurgery, epilepsy surgery has got a huge potential. And then the current technology allows us to connect very nicely with various institutions. We have been mentoring some institutions outside India, within India.
Okay.
So outside India, we have helped to develop epilepsy surgery programs in countries like Indonesia, Morocco. And within India, we are collaborating with some centers like the Neuro Foundation from Tamil Nadu, where we are creating a technology-driven outreach program where we are enhancing their capabilities so that they can build their own independent epilepsy surgery program.
All right. So in that case, if you could directly, or if you have to directly speak to the patients or the families dealing with uncontrolled seizures, then what's that one thing you would want them to know about the treatment possibilities?
Maybe Dr. Manjari can answer this.
I often tell them that the only thing that you should know is that enough time has been lost. As Dr. Chandra said, many of them come to us 15 years after refractoriness, and maybe you would have been seizure free much earlier had you come before to the center and got evaluated, and also by now got operated. Based on the modern technologies, which were not available when I was doing my DM neurology. We didn't have so many platforms. We didn't have fusion of platforms. This is the only thing I tell them, that do you know that it is possible to have seizure freedom and probably get back your lost aspirations? Start now, start here. So this is the only thing I tell them, and some of them are very eager and they get into the program, they get evaluated. Some of them, particularly during COVID, we lost many patients, and now they're coming back again and they're still refractory. So, COVID was in 1920, and then they are coming back in 25 and they're still refractory and they were lost to follow up. So the only thing I tell them, that it is possible to imagine that you are going to be seizure free, and we can come down on your medicines from 3 to 2 to 1, and maybe even that 1 will go. So that only time will tell, but that is a possibility.
No, absolutely. But doctors, what would you say to sort of encourage earlier referrals for surgical evaluations? If I can start with you.
So when I speak to the patients, I often find that the patient and the caregivers are overwhelmed by an immense sense of fear. There is a lot of fear, particularly with epilepsy, because of the things they have heard from the society. It could be associated with lunacy, it is associated with spirits, evil spirits, it cannot be cured, and you cannot marry a person of epilepsy, you should not eat food from a household where a person has epilepsy. So there are so many factors which contribute to the fear. So I tell them that this is a time when you need to move from fear to understanding. Because when you understand that it is just like another disease, is the way forward where you can help in treating this disease. And if you treat one person with epilepsy, you are changing the entire connection of the caregivers around them. The quality of life of the parents will improve, the brothers will improve, the sisters will improve, even everybody else in the household will improve, because all the time they have been so worried with this person who's having epilepsy that their own careers, their own progress in life has been cut short.
That's a very great way to sort of look at this, and perhaps that has been the aim of this conversation as well, to raise the awareness around epilepsy and all the other treatment options that we do have now because of the technology. But before we end this conversation, I do have a rapid fire round for both of you. I'll start with you, Doctor. We'll end with you. It's a rapid fire round. Either a one word or one sentence. Be rapid, right? I'll start with you, ma'am. The biggest myth about epilepsy you wish would disappear overnight?
Epilepsy is something which we need to hide.
All right. Then one thing you wish every family of an epilepsy patient understood?
That normal life is possible.
Perfect. A medical breakthrough in neurology that excites you the most right now?
The fact that we can visualize which neurons are firing at what time point in 3D, in which area of the brain, that is what excites me.
Yeah, that's really exciting as well. If not a neurologist, ma'am, what other profession would you have chosen?
Nothing else. Absolutely nothing else.
All right, he had a reaction to this question. Now, one word to describe the future of epilepsy care in India.
I think we have miles to go before we can rest. We need to transform more lives. We need to remove the stigma. We need to see that girls with epilepsy are not discriminated and removed from marriages. We need to make people understand that having epilepsy is the same as having a blood pressure, diabetes, asthma. Anybody can have it at any point of time.
All right, then, who has been your biggest inspiration in the field of neurology?
For me, my mentor, Professor Jerome Engel from UCLA, when I was training in neurology, he used to come to India to give us talks, and he kindled my interest in seizures.
Okay.
And what I find most fascinating about epilepsy is that it is unpredictable. And that unpredictability makes it challenging.
Yeah.
And if we can convert this unpredictability to a more predictable life for a person with epilepsy, that is something which will put my knowledge to use.
All right. One last question. If you can spend a day with any neuroscientist, past or present, who would that be?
I think it would be, again, Professor Jerome Engel, because the way he has, when I was doing my fellowship, he guided us in learning, is something which I cannot forget.
All right, moving to you, sir. The first question, the most rewarding moment for you after a successful epilepsy surgery?
Is when you see the sense of happiness on the faces of caregivers. Initially they would not believe that the seizures would be cured.
Yeah.
But they find as soon as the surgery is done, in good cases, okay, you have a spectrum. So when the surgery is done, within 3 or 4 days, when they don't have seizures, you could see that sense of hope coming on the faces. I think that's really.
All right. All right. One innovation or tool that completely changed the way you operate?
Well, I have been fundamentally developing some technologies for epilepsy surgery. And 2 of them have been an endoscopic driven hemispherotomy, where you disconnect the whole hemisphere through a very small opening.
Okay.
This has been published and been now practiced globally. And the other is a percutaneous hemispherotomy, which is a bloodless technique. And both the innovations are very, very important, because in the latter especially, there is absolutely no blood loss, and it has converted a maximally invasive procedure where you need to do a large craniotomy into a percutaneous bloodless technique. And both the techniques are made in India. Techniques which have been validated, which have been published, have even come into various textbooks.
All right.
So these are the techniques which have given me a lot of satisfaction.
Perfect. Then a quality every neurosurgeon must have beyond skill. What would that be as per you?
I always tell my residents that you first have a good marriage and then you can be a successful neurosurgeon.
That's a great advice. Then if you could collaborate with any medical innovator or company, who would it be and why?
There are so many of them, but I would be very interested to collaborate with the technology companies, because I believe that technology companies can provide what we are lacking in, and we could make up potentially very good partners together. So that's something.
That collaboration will perhaps work when we talk about the future of epilepsy care in India, especially. On that note, one word that defines your vision for technology-enabled surgery.
So we are going to see a lot of technology-enabled surgery, where more and more paradigms are going to embrace and create more and more surgical techniques. So as surgeons, we should not think that that is reducing our surgical capabilities. It should allow us to seamlessly embrace these technologies, because at the end of the day, the stakeholders are the patients. So if you are able to deliver a more effective, safer technique for the patients, and so that I think is the ultimate goal of any physician or a surgeon.
Yeah. Okay, then the same question that I asked her also, if not a neurosurgeon, then what other profession you would have chosen?
I really don't know. I think
It's been a lot
doing
of
neurosurgery since so many years. Yeah. So I love doing this profession. So at this point, I don't know. I really can't think.
So
of an
what do you
answer.
do after, when you go back to your home after
I
work?
do have a couple of hobbies on a very personal level. So I have, my hobby is to, perform Vedic chants
Oh,
in a very good frequency. And the idea is that Vedic chants, I believe, are something like auditory neuromodulation. So we do various types of neuromodulations like vagal nerve stimulation, deep brain stimulation. Ultimately, they're delivering electrical impulses. But with the way Vedic chants have been designed is that you utter them in a particular frequency. They are going to hit your auditory cortex, be converted into electrical impulses, and have a very good positive effect on your brain. So that's something which I do during my pastime. And the reason I do it is it's very satisfying. It's very simple. You don't need any complex things to do it. And I do have a guru who teaches me this twice a week on Saturdays and Sundays.
Great. This perhaps can be the topic for our next podcast someday. It's really interesting. On that note, just last question. Who has been your biggest professional inspiration in the field of neurosurgery?
So in India, of course, Professor P.N. Tandon, who has been the founder and emeritus professor of this department. And then I like to acknowledge Professor Gary Mathern in UCLA, from whom I have learned how to very effectively combine your clinical practice into research. He was one of the few surgeons who had an epilepsy neurobiology lab where all these basic scientists were working with him, and together they were collaborating on a research algorithm for epilepsy. And that inspired us to create our own neurobiology epilepsy lab here in India, the first of its kind for our country, where we now have a lot of basic scientists. So we give them brain tissues and they are able to do basic neurosciences and research to understand how are the brain connected, how is the connectomics, how does the neurons come, what are the genomics, a lot of things. And we have published more than 100 papers on this subject into some of the highest impact factor journals. And this wouldn't have been possible if you have not been able to create a complete research team.
All right. Thank you so much for sharing your perspectives. It was really a really insightful conversation that we had. Now, what we have heard and what we have understood is that epilepsy care is evolving, yes, and the shift isn't just medical, it's more technological, it's collaborative. And when different platforms like when neurosurgeons or neurologists or innovators or technology platforms perhaps come together, that is where we can see the real outcomes, and that is where the fear gives way to hope. Well, thank you so much for being a part of this conversation, and to our viewers, stay tuned for many more such insightful conversations only at ET Health World.